This is a series of lectures on why is there so little relief for musculoskeletal problems relative to other disorders like cardiovascular disease and neurologic problems, or what another way it can be put is why are so many people disabled by musculoskeletal conditions. This is part one of a series. In part one, we're going to focus in on dysfunction within the medical system itself, and then in later lectures, we'll move on to topics like kinesiology, comorbid disease, and neuromuscular dysfunction, as well as integration with PT and fitness centers. My name is Dr. Mark Brzezinski. I'll go into my background and who the presentation is with shortly. Now, of course, these lectures are educational and not intended to manage individual patients. They are not a substitute for patients seeing healthcare professionals. Among the reasons are patients vary and no brief presentation substitutes for formal training, though many people would like to believe that. These are common statements we hear in our patients. Why do I have chronic back or knee or shoulder pain in spite of all the specialists I've seen and all the therapies I've endured? Or how do I reduce my chances of injury, both with activity and age? Can I maintain a high level of function in later years of life? I want to still be able to walk when I need to go places and be less dependent on others. Another is my doctor says my joints hurt because of age and I should schedule a joint replacement. Is there an alternative? Finally, in the world of fitness, I want to lose weight, but I keep having problems with my knees and back when I exercise. What can I do? So what we're really trying to do is increase function with age, non-surgical injury restoration, injury prevention, and smart fitness. So besides being a doctor, I'm also the CEO of the Functional Movement and Fitness Corporation, also known as C's Health. My background is I'm a functional movement and fitness specialist since the mid 90s. Most of my career has been spent with Harvard Medical School and Massachusetts General Hospital and or Brigham and Women's Hospital. I did my residency in internal medicine at Harvard Brigham and Women's. My fellowship was actually in cardiology, which is well suited for translating into this field at Massachusetts General Hospital, Harvard Medical School, which cardiology sees most of the other specialties in medicine and surgery. I also have an engineering background, which is well suited for kinesiology. I have a PhD in exercise physiology. I'm a certified personal trainer. I learned most of my physical exam skills through physical therapy and orthopedics. I officially moved out of cardiology and orthopedics in 2000 and became a member of the orthopedics department at Harvard Medical School and Brigham and Women's Hospital. I'm the first person to have ever won the presidential award for I won it from President Clinton, the first person to ever win it in musculoskeletal disease. And I've been on over 80 NIH committees, including the oversight committees for the NIH Osteoarthritis Initiative a bit since 2002. You can read the rest of my background on the website. Is the treatment of musculoskeletal more difficult because it's just these conditions are much more complicated than other medical conditions? No, of course not, but they are complex conditions that are generally being treated at this point in time relatively simplistically. The change attire approach is very common in this field. not taking into account kinesiology or kinetic chain, neuromuscular dysfunction, and particularly the medical components, co-morbid disease, musculoskeletal disease presenting as uh, another medical problem, or another medical problem presenting as musculoskeletal disease. Now, this is one of the major problems. If we look at fields like neurology and cardiology, they're the medical branches which have a corresponding surgical branch, neurosurgery and cardiac surgery. We have orthopedics, but there is no internal medicine branch to it. So patients are left looking for non-surgical answers elsewhere in an uncoordinated manner. I believe the long-term, and we believe the long-term solution is medical fellowships in this area, which I attempted at Brigham and Women's Hospitals, but the complexities of starting off a 3-year fellowship from scratch is very difficult. So the compromise was to start in the short term with C's Health. And what C's Health does specifically is not the focus of this particular video, and you can read more about it on the webpage. So again, these are our goals. Okay, some of the basic problems we see, and this is across specialties, and I'm going to emphasize it, from MDs to athletic trainers. Uh, it, there's a lot of people who don't have great basic training skills. Their physical exam skills are lacking, and they often rely too heavily on imaging. The Very few people incorporate the kinetic chain. Very few people will incorporate really detailed neuromuscular dynamics. Often you'll have people mentioning it, but they're not incorporating it. Comorbid disease is poorly incorporated, and integration between PCPs and PT and trainers is almost non-existent. It's basically a black box approach. They're just sent to PT or trainers without being followed afterwards. And I'm not going to go into detail on the kinetic chain, but I just want to give people an idea who don't already know about it. We're based out of Marblehead, Massachusetts, which is a coastal city, but this is I have a lake house near here on this photograph in Pennsylvania, in the largest natural lake in Pennsylvania, and I'm presenting it for the purposes of analogy. Houses on this lake have problems with their foundation, but the problems in their foundation aren't due to weak foundations. They're due to the fact that water comes down the mountain at very high speeds, and winds off this massive lake are very high. But people who just sit and patch the foundations are going to continuously do it. They're not fixing the problem. They need to redirect the water and redirect the wind. And that's how we approach many musculoskeletal problems. That's how we approach back pain, which is generally due to problems below the waist. Knee pain is generally due to issues with the hip or the ankle. And this slide, both these slides are proprietary. The slide on the left, we generated through a kinetics program. So when you invert your foot, it automatically turns your knee in, causes your hip to bend downward, go more inferior, and it produces an arch in your back. So you have lateral displacement of the spine. If you do this while you're walking, each time you have impact, you're causing problems through all these joints, including the back. Now, the picture to the right comes from the textbook Kinesiology of the Musculoskeletal System, and we've paid royalties on the rights to present this photograph or this image. And both photographs show two forms of sitter's disease, where the hip flexors or the hip extensors are short, and the impact of that on the spine. So if we look in the upper left-hand corner, A, we have excessive lordosis, bending of the spine. And if looking below at C, what that does at the L1, L2 disc, for example, we see that the space that the intervertebral nerves come out of is tightened, and if there's a disc in that space, it's going to cause the disc to compress onto the nerve. And we also see that the anterior ligament is just one of the structures that's stretched in this position. Now, if we take in B the opposite, the A was anterior tilting of the pelvis. B is posterior tilting of the pelvis. We see that the interspinal ligaments, green arrow again, are stretched and damaged, causing pain. In addition, the intervertebral disc now bulges inward onto the spinal cord and can worsen spinal stenosis. I'm going to go through some of the problems we see with individual practitioners, but again, it stretches through from MDs to um, athletic trainers or trainers. And so I'm giving examples of people in the field from different specialties who I consider to be excellent and have learned a lot from. Uh, so some of the problems we see first is simply training fundamentals. Again, getting back to it, it's a field that's heavily dependent on history and physical exam skills, but we see some physicians who seem to only know about 10 things that can go wrong with the knee when there's, several hundred. Now, the Dunning-Kruger effect I would encourage people to read about, and it's not limited to medicine. Um, Basically, giving the Cliff Notes version, when somebody has a little bit of an education in an area, they tend to be overconfident in their knowledge base, where somebody who has an extensive amount of education in an area tend to be underconfident. And we see this is a very, very big problem in medicine. You see people are in this field of musculoskeletal disease learn a handful of diagnostic techniques, and they the level of competence they feel they have is uh, is nowhere near what their actual skills are. I mean, we see it with patients, the classic patient who's read about a diagnosis of a disorder that has an incidence of 1 in 50,000 on the web, and they come in convinced they have it. On the other extreme, I mean, when you've been a physician in a big city hospital for a long period of time, you second guess everything. And so you ask a lot. You ask the nurses, you listen to the opinions of the fellows, the residents, because your goal is to get what's right for the patient. And so it's not to be somebody who's right all the time. And a lot of people are just going beyond their education. You run into people who call or lead their patients to believe they're physicians, or actually call themselves physicians who are doing, uh, you know, practicing in areas they're not really trained to practice in. Um, One of the most important lessons, and this doesn't just have a liability issue, malpractice issues. This could actually have criminal consequences, which I've seen happen. One of the important lessons, I don't know who told it to me, is it's really critical to know what you don't know. And that sort of saved me throughout my medical career from making any major medical mistakes. I mean, when you know what you don't know, you know to ask or to look it up. And there's nothing wrong with looking it up, because even the best practitioners across all fields don't know everything. And the field relies heavily on imaging and arthritis. And I'm going to just give a couple examples in the next slides, but MRIs, I think a lot of people think it replaces the physical exam, and it doesn't. I want to go back to so I'm going to give a couple examples. So the first example is I saw a patient a few weeks ago who got a cursory knee exam, and on x-ray they saw some degree of arthritis, and the physician who saw them told them they need a knee replacement in 6 to 9 months and sent them back out again. Well, their underlying problem was iliotibial band syndrome, and so with a few weeks of physical therapy the problem went away completely. Another patient I saw within the last week had bilateral trochanter bursitis, and when she's about 44 years old and a walker, and her exam was actually negative for most tests for iliotibial band syndrome, though that's what you usually associate with trochanter bursitis. But when she went down into a squat, she had massive internal rotation. It turned out her femoral necks were antiverted substantially, and this was completely missed. And her recommendation by the person who had seen her originally was just walk up steps less. And I'm going to go into this study in more detail in a later video, but and it may be on the web page. I'm pretty sure actually it is on the web page. A study was done in patients with no symptoms of their shoulders. MRIs were obtained, and in something like 70% of the patients, median age around 37, they had abnormalities which could be considered surgical. These are asymptomatic patients, and so imaging is not a substitute for a physical exam. And another issue is somehow it seems like when people get in trouble, when they've reached the end of their knowledge base, they label a lot of things as arthritis. And so I saw a video recently. I try to keep up on and do videos pretty frequently, where the practitioners had become familiar with femoral neck fractures and how to examine for femoral neck fractures. But when they got to the question of how you measure joint stability in the hip, they basically looked like deer in headlights, and they started rambling and then ultimately just said it had something to do with arthritis. And obviously you need to be able to measure stability or instability, particularly in the significant number of people who have hypermobility syndrome. Similarly, in another video, I saw practitioners who were talking about femoral neck fractures, and they demonstrated the tests and were somewhat excited that they could identify when somebody had a high probability of femoral neck fractures. But they did something that people do a lot of. They listed all these medical conditions that it also can be. So groin pain can be an ectopic pregnancy, a pregnancy, kidney stone, a hernia, a whole range of problems. But their recommendation, and I hope they just missed the point and they don't really practice this way, was then these relatively young childbearing age patients, they said immediately send them for x-ray. Well, obviously, if they can have an ectopic pregnancy, they can be pregnant, and you just don't want to radiate them. And I've spent a lot of time as emergency room physician in major city hospitals, and the number of immaculate conceptions I've seen in my lifetime is huge. You'll ask a patient, could they be pregnant? They tell you they haven't had sex in 1 or 2 years, and their pregnancy test comes back positive. And so, you see this even with like medical students. People think medical students, or at least it's been my experience, are most concerning when they start, or fellows or residents, at the beginning of the year, and this Dunning-Kruger effect seems to kick in more 6 to 9 months when they know enough to be dangerous and they stop asking questions when they should be. So the current approach is, and I'm talking about chronic, not acute. Obviously, when you have acute swelling of the knee, acute swelling of the back, you do use local therapies. Chronically, we're not, it'll alleviate most of the problems we're talking about. We're not talking about local therapies. We're talking involving the kinetic chain, the nervous system, and and currently rehabilitation is short term, which we propose extending it into the fitness center, or some of it going directly to the fitness center, and communication between physicians and PT and fitness centers. And so that's the C-Cells approach. So better education for physicians, everything from basic physical exam to kinetic chain, neuromuscular dysfunction, and also better integration with fitness centers and PT. I'm going to run down the list again, but I'd like to thank the National Institute of Health, the NIAMS, who supported my research since the 90s, and NIBIB and heart, lung, and blood to some degree. But the NIAMS gets about 1/10 of the amount of money that the National Heart, Lung, and Blood and National Cancer Institute gets. But they do an incredible job pushing this field forward anyway. And we really do need more money in research. You look at a lot of the clinical trials, and they have 5 patients, 10 patients. And in cardiology, you're used to seeing trials that are thousands of patients. So a lot of times you're just going on logic and instinct. So again, these lectures are educational and not intended to manage patients. They are not a substitute for seeing healthcare professionals. And again, among the reasons our patients vary, and a brief presentation is not formal training. Thank you.